We're going to speak for the next few minutes about esophageal trauma. If we define trauma as an injury to living tissue caused by an extrinsic agent, including surgical trauma, then what we're going to discuss today would include penetrating and blunt traumatic injuries, as well as those injuries caused by physicians or iatrogenic trauma. What we're really talking about is esophageal perforation caused by a number of possible etiologies. These are broadly treated in the same way. And for example, although a Boerhaave esophagus or spontaneous perforation that is caused by retching is not specifically included, many of these principles would apply. The treatment of esophageal trauma has not changed much over the last few decades. It remains a very lethal injury. Overall mortality can largely be determined by the time at which a patient is taken to the operating room. For those discovered early, that is sooner than 24 hours after injury, mortality can be expected to be approximately 10 to 15%. When operation or diagnosis is delayed, mortality can certainly be above 50%. Of all esophageal traumas or esophageal perforations, approximately half are caused by instrumentation of the esophagus. 20% of those are caused by trauma. 16% are spontaneous. 7% are caused by foreign bodies, which are discussed elsewhere in the curriculum. 8 are due to operative misadventures. And another 7% are related to tumor and other miscellaneous injuries. Of the instrumentations, approximately 35% are the result of endoscopy alone, 25% due to pneumatic dilatation, 20% due to bouginage, and another 20% secondary to problems with endotracheal intubation and various other tubes such as Sengstaken tubes, NG tubes, and sclerotherapy. Transesophageal echocardiogram is gaining greater and greater application, particularly in cardiac surgery, and is certainly routine at most places. The overall risk of esophageal perforation during instrumentation of just about any kind is in the neighborhood of 0.03%. Although quite small, the potential injury is quite great. Esophageal anatomy is covered elsewhere in the curriculum, but I will make a few points specific to this topic. The esophagus is, of course, a muscular tube made of cervical, thoracic, and abdominal portions and is approximately 39 to 48 centimeters in total length. There are no major neurovascular attachments and there's no serosa, and this, of course, allows us to complete transhiatal esophagectomies as we do. In general, there are 3 deviations from side to side, the first being a leftward deviation at the base of the neck. The esophagus then swings back to the right at approximately the level of the 7th thoracic vertebrae and back to the left side at the diaphragmatic hiatus period. There are no compartmental barriers within the chest or neck, and this allows for the free progression of infection, particularly those perforations in the neck can rapidly cause spread of bacteria and infection into the chest, virtually anywhere in the mediastinum. The contents of esophageal perforations are toxic, that is, they contain amylase, lipase, and gastric contents, the design of which is to digest food. And of course, there's no extra length to the esophagus, as you would find in small intestine. It's very difficult, of course, to mobilize enough esophagus to perform an end-to-end anastomosis, and this just isn't done. This cartoon demonstrates the multiple spaces within the chest and neck, from the pretracheal space to the retrovisceral space in the posterior mediastinum. Infection can rapidly spread to any of these compartments as there is no clear definable barrier to their progression. There are 2 factors that would limit esophageal trauma. First of all, the esophagus is well protected by the surrounding structures, both in the neck and in the thorax. Unfortunately, injury to these protecting structures often results in early death. For example, injury to the thoracic aorta may not give us opportunity to ever evaluate the esophagus. Cervical injuries are far more common than thoracic ones. Penetrating injuries occur from gunshot wounds and stab wounds from many objects ranging from knife blades to ice picks, combs, and numerous other weapons. Blunt injuries of the esophagus are uncommon, accounting for less than 0.1% of trauma patients, but they carry similar mortality. 50% of these are associated with tracheobronchial injuries, and although these are rare, one must maintain a high index of suspicion, especially when a tracheobronchial injury is identified. Perhaps the single most important message from this discussion would be that a delay in diagnosis translates to a higher mortality. The typical progression from the time of perforation would include chemical mediastinitis, multisystem organ failure, and then death. Rupture of the esophagus from blunt trauma can occur from the sudden forceful displacement of air into the esophagus against a relatively closed upper esophageal sphincter. This may be caused by a sudden increase in abdominal pressure forcing gastric air into the esophagus. This can also be caused by compression against the vertebrae with or without bony prominence of the vertebrae, which could also contribute to an injury to the esophagus. The most common site of blunt injury is the distal end. Injuries in blunt trauma are typically longitudinal and can be quite extensive. Again, considering the diagnosis is half the battle, the injury needs to be ruled out in all patients with tracheobronchial injury, penetrating injuries of the posterior mediastinum, and any injuries which involve projectiles that traverse the mediastinum, or any high-impact trauma to the chest or abdomen. Findings may range from quite subtle to the very obvious. Signs and symptoms that may be present would include chest and or abdominal pain, dyspnea, cyanosis, tachypnea, shock, elevated temperature, subcutaneous emphysema on palpation, odynophagia, and particularly with cervical injuries, patients may complain of a stiff neck. Even with passive flexion, pain may be elicited. Commonly obtained chest x-rays may reveal only a pneumothorax with or without subcutaneous emphysema visible, wide mediastinum, hydrothorax or hydropneumothorax. Mediastinal crunch on auscultation may be elicited, and abdominal free air or pneumomediastinum may also be seen on chest x-ray. How do we make the diagnosis? Well, again, the first step is considering the diagnosis and always maintaining that index of suspicion. Typically, first step would be esophagography or a gastrograph and swallow. A liquid soluble solution is typically used as a first step, that is gastrograph, and this may demonstrate a leak. When it does not, we would typically follow this by a barium material for a more sensitive study. Esophagoscopy can also be used, looking for an area of erythema or frank demonstration of a perforation. Both of these studies have a not insignificant false negative rate. CT scanning can also be used through direct or indirect evidence on the scan. Perforation can be demonstrated, but this would typically be confirmed by one of the above studies. And of course, exploration and direct examination of the esophagus is always possible, particularly if the patient is going to the operating room for another reason, that is a vascular injury or other injury to the mediastinum. At that point, then, the esophagus should thoroughly be explored, period. This can be performed similar to testing a bicycle tire underwater. After mobilization of the esophagus, it can gently be occluded with a Penrose drain or a finger distally and air insufflated through a nasogastric tube. The absence of any observable air is a relatively good test for ruling out an injury. However, all of these have significant false negative rates, and a high index of suspicion must be maintained. Often many studies may be necessary, and if first test is negative but the suspicion continues, repeat studies may at that time demonstrate a leak. This is also true in the postoperative setting, where a repair may in fact break down. Next slide. Treatment of the leak or perforation is similar to perforations elsewhere in the body. It would of course include eliminating oral intake, intravenous antibiotics, and an NG tube, although there would be some concerns that placing this could further leak or propagate the tear. It nonetheless is likely indicated. Every case is slightly different and will require a tailored approach. The four basic concepts would include debridement, direct repair when possible, drainage always, and diversion when necessary. Debridement is almost always indicated. This shows a CAT scan of a man who suffered a distal esophageal perforation that was not discovered well into his course. The CAT scan demonstrates a significant right-sided collection, so much so that the mediastinum is deviated to the left. There is both fluid and a large amount of phlegmon, if not frank necrotic material, present within the mediastinum, which must be thoroughly cleaned in order to provide the best outcome. On the left is a cartoon demonstrating the ability to fully mobilize the esophagus, as seen through the right as seen through the left pleural space. The right mediastinal pleura can be demonstrated. On the right side is a thoracoscopic picture through the right chest, demonstrating the esophagus being mobilized in the left-hand side. Debridement may involve esophagectomy, but certainly in rare cases and only if the patient is stable. Perhaps the most common role for esophagectomy would be if a malignancy is involved and known up front, and again should only be undertaken in a very stable patient. Direct repair should certainly be undertaken when possible. There has been some controversy in this area over the last few decades. Initially, there seemed to be some golden time frame during which repair should be undertaken, which initially might have been 12 hours and seems to have been extended over the past many years up to 18, 24, and I believe that most surgeons at this point would attempt direct repair if possible. That is, if the contamination and necrosis was not too significant and if the patient were stable. I do not believe there is a magic cutoff time, and there are certainly many case reports in the literature of successful repairs occurring many days after perforation. The approach to the esophagus in the chest would be determined by the location of the injury, with a right-sided approach generally directed to the middle and upper third of the esophagus and a left-sided approach to the lower third. However, the direction of the leak on your barium or gastrograph and swallow should also be considered, keeping in mind that the aortic arch would block an approach to the upper esophagus. The cervical esophagus is typically approached from the left side unless there was strong evidence on your gastrograph and swallow to indicate an injury to the right, or certainly if a stab wound or other injury directed your exploration to that side. The cartoon demonstrates a two-layered approach with debridement first of the muscular layer, a direct closure of a mucosa using an absorbable suture, and closure of the muscular layer using a non-absorbable suture. A one-layer closure would certainly be acceptable and is performed by many. These two drawings demonstrate approach to cervical injury both being approached from the left side. The esophagus is revealed as the sternocleidomastoid and carotid sheath are retracted laterally. The cartoon on the right demonstrates a direct repair of the esophagus with the carotid sheath retracted laterally. Most would agree that after closure and repair that a vascularized flap should be placed. The choice of flap is dependent upon the location and the experience of the surgeon. I believe that the intercostal muscle flap is quite versatile. It's easy to harvest and can reach just about anywhere within the chest. It's well vascularized and is of adequate size to cover most injuries. The pleura has been advocated by some. The pericardium has been used by some, although this could certainly contaminate an otherwise sterile compartment. The pericardial fat can also be used. Omentum has been used, and certainly with abdominal injuries, gastrocardea can be used as a patch. When in the neck, strap muscles, omohyoid or sternocleidomastoid muscles can also be used. Despite enthusiasm for primarily closing injuries, the fact that the leak rate is certainly higher persists, and up to 50% of repairs completed after 24 hours may leak. Keeping this in mind, if a patient fails to improve, consider a leak again and rule it out. At this point, then, diversion may be the only option for the patient, particularly if they're unstable. Drainage is performed always, even in non-operative management, which is discussed later. Drainage will take many forms, most commonly in the forms of chest tube placement, either at the time of thoracotomy or before. T-tubes have been advocated by some if a direct repair is not possible. That is, a large bore T-tube be placed directly into the esophagus, draining out through the chest wall. This has met with varied success. The newer Blake drains I found to be quite useful when directed drainage as necessary, owing to their freedom from clogging, their flexibility, and the relative softness of them, allowing them to be brought out more posteriorly than a typical chest tube. When perforation is discovered in the neck, drain should be placed well into the mediastinum. While some advocate placement of Penrose drains, others believe that suction drainage is necessary given the fact that gravity is working against you, period. G-tube and J-tube drainage should also be included. Rather, G-tubes are often placed for drainage of the stomach, while J-tubes are placed for feeding in what may be a continued period of inability to feed via the mouth. Diversion is performed when necessary. Cervical esophagostomy is disfiguring but a life-saving operation. If someone's life is at stake, don't hesitate to perform this procedure. Certainly clear discussion should be taken out with family and patient if possible prior to performing this maneuver, as it will certainly result in, at a minimum, many-month course of what is a very unpalatable thought to everyone. Always bring out as much esophagus as possible, that is, bring it out as distal as possible. Remember the surgeon who's going to have to do the reconnection with what will be a conduit that is limited in length. When performing the cervical esophagostomy, the distal end should be stapled. This will then retract into the chest and will not be usable for later connection. Non-operative management is occasionally indicated, although some would meet this with great controversy. Some indications for treating esophageal perforation non-operatively may include a very small leak, one which drains back to the GI tract via the esophagus, a contained mediastinal contamination. This can be seen in patients who have had previous scarring, either due to infection or some other process such as radiation. There has been literature reported recently, as well as a feeling for quite some time, that perhaps in children a non-operative management may be preferable, and a recent article published in the Journal of Pediatric Surgery is listed below for your review. The specific how-tos of handling esophageal perforations remain quite varied. A recent article was published in the European Journal of Cardiothoracic Surgery, which included 75 patients treated over 15 years. There were many etiologies for the perforation, with a median age of 63 years old. The overall mortality in this fairly large group was 16%. Those who had immediate diagnosis had a mortality of 5%. Those with relatively early diagnoses had a mortality of 44%, and if the diagnosis was delayed beyond 24 hours, the mortality rate was 44%, with a significant p-value. The site of perforation, the etiology of the perforation, and the treatment strategy had no effect on the outcome. The authors concluded, as I've said before, that prompt diagnosis and rapid patient-specific treatment affects the outcome. This slide demonstrates a relatively young woman in her 20s who has a history of tuberculosis, and we suppose due to that had a very scarred pleural space. She presented to the thoracic surgical service almost 2 weeks after the sudden onset of chest pain, which was almost certainly a spontaneous esophageal rupture. The slide on the left shows the perforation, which was demonstrated on CAT scan. When contrast was given through this, there was some spread of contrast into her pleural space, but contained presumably from her previous scarring. The patient remained quite stable with a normal white blood cell count and no temperature. She was treated non-operatively and with an NPO status and hyperalimentation. The CAT scan on the right was obtained 1 week later, demonstrating resolution of the small leak. She subsequently returned to a full diet. Remember, of course, that certainly that patient would not be the norm. This next case is certainly more typical. This is a 50-year-old man who underwent panendoscopy for an ENT cancer, and during the rigid esophagostomy portion, an inadvertent injury to the distal third of the esophagus was made. The patient initially presented with shortness of breath and chest pain. The slide on the left is quite subtle, with the only finding being a small left apical pneumothorax. Maintaining a high index of suspicion, a gastrograph and swallow was obtained, which is shown on the right side, demonstrating free flow of contrast material from the esophagus into the left pleural space. The patient was taken immediately to the operating room, where a direct repair of the injury was done after debridement of the necrotic material. Closure was carried out in a 2-layer fashion, and the injury was covered with intercostal muscle. The chest was widely drained with chest tubes. NG tube was placed in the stomach, and the patient remained NPO for 1 week. After that, this barium swallow was obtained, which demonstrates no further leak. There is some mild narrowing in the area of the repair. 3 months after his repair, the patient has no dysphagia and has normal swallowing function. This would be initially managed if it presented with dilatation. In summary, always maintain a high index of suspicion. Rule out injury aggressively multiple times if necessary, preoperatively and postoperatively. Intervene early, remembering the 4 tenets of repair, including debridement, direct repair if possible, drainage and diversion when necessary. Mortality can be minimized. And finally, each of these patients will present slightly differently, and each will require a creative and tailored approach to their management. the last and final slide lists many of the references used in the preparation of this discussion. Thank you.